So the irritable bowel syndrome, like any medical condition with the name syndrome in it, is in fact a collection of symptoms which keeps cropping up patient after patient. So we think it must be a real condition, but as yet we don't understand all of the detail, and in particular we don't understand the cause. So it's difficult therefore to define it as a disease. Because it's a collection of symptoms, that creates its own difficulty, and in particular there's no single diagnostic test that proves that the irritable bowel syndrome is present. So testing is designed to rule out other things that might be mimicking irritable bowel, things that are important to rule out. And therefore it is possible for irritable bowel to be misdiagnosed. Perhaps a doctor doesn't listen to the history properly, doesn't do the right exclusion tests, is too quick to make that diagnosis. Perhaps the patient has made it for themselves. So always revisiting the diagnosis, listening to the history. Is it a real diagnosis? Has it been made properly? Have the right things be excluded is really important. So in general, irritable bowel syndrome is a younger person's problem where we worry less about cancer. And so in younger people, the two particular conditions that are really important to rule out, one is celiac disease, which is a particular medical condition associated with the gluten fraction of wheat. And fortunately now we have a very accurate blood test, which can be easily done by general practitioners or specialists to rule out celiac disease. The other main disease are a group of diseases known as inflammatory bowel disease, primarily ulcerative colitis and Crohn's disease. And we now have a very accurate and easy stool test called fecal calprotectin. Again, many GPs will be using this and specialists. So if the fecal calprotectin is normal and the celiac screen is negative, that is a really good rule out of irritable bowel mimics. You do need to listen to the history. There are other problems which can, if you listen very carefully, for instance, if the patient's opening their bowels at night, waking them up, that usually isn't irritable bowel. So there are little tips and tricks, but those two are the primary rule outs. In older people where we worry about cancer, particularly bowel cancer, we now have accurate testing for chemical traces of blood in the stool, which is used very widely as a cancer rule out, but it may then be necessary to do endoscopies to absolutely rule out cancer or scanning or both. And in women, the other concern, particularly if there's a lot of bloating, is ovarian cancer, and that can be looked at with appropriate blood test markers and also pelvic scanning. So irritable bowel syndrome, although it doesn't have a diagnostic test, is accurately defined by a consensus of specialists, the so-called Rome criteria, because they were defined at a conference in Rome many years ago. And the three cardinal features of irritable bowel are some degree of abdominal pain, quite a lot of abdominal bloating, and some sort of disturbance of bowel pattern, which could be more towards constipation, could be more towards diarrhea, or could be a mixture of both. And the add-on is that the pain, cramping pain, tends to be relieved by bowel action. So those are the important symptoms of irritable bowel. The important concerns that might make one think that it isn't irritable bowel would be rectal bleeding, which is not due to irritable bowel, or could be there by coincidence from something simple like hemorrhoids, piles, but it's not due to irritable bowel. Irritable bowel does not cause weight loss, and in general, irritable bowel does not cause vomiting. So I've hinted at that in a previous discussion. I mean, I think it is reasonably clear that pain, bloating, and bowel disturbance are irritable bowel, and rectal bleeding, weight loss, and vomiting generally aren't. So that would seem to be clear cut. Nausea is more vague, and certainly irritable bowel can have a nausea component, but there are other causes like ulceration or even things like pancreatic cancer or gallstones. So that's a symptom to be thought about and analyzed separately. Weight loss is always an important concern. There's a wide variety of causes, which might be to do with the tummy or might be more general, like thyroid disease, or of course, depression will often be accompanied by weight loss. And the psychological side of irritable bowel, is there a specific psychological trigger for the irritable bowel in this patient, or is there associated psychological issues and problems, is something that the general doctor, the non-psychiatrist, still needs to be very aware of and have the ability to appreciate and analyze to some degree. So this is always a difficult question, because the way that people perceive their symptoms and the way they worry about their symptoms is hugely variable, person to person, patient to patient. And fortunately, of course, in the UK, we have free and open access, with some degree of waiting, but nevertheless free and open to general practice and to the emergency department. So the particular things patients should worry about in relation to the tummy area, the GI tract, are unintentional weight loss and rectal bleeding that persists for more than 3 weeks. Those are two particular worries. The third one, for people who are older and might be in the category of bowel cancer risk, so that's certainly over 50 and increasingly over 40 and possibly even in the 30s, is some sort of change in the character of the bowel that persists for more than 3 weeks. The way that they go to the toilet has changed and remains changed. So those are the particular worries, but I think I would have to encourage people to consult a doctor, probably a primary care doctor, really if they're worried, if they feel that something's not right with the tummy area, with the tummy functioning, and particularly something that's new or different, not over a period of days, but certainly over a period of weeks or months.